ovarian torsion forms a major bulk of acute pelvic pain or sudden acute pelvic pain that presents to the ER. The problem is the variable imaging appearance associated with ovarian torsions. So we will try to look at the various grayscale and color Doppler appearances and try to come to a decent way to diagnose ovarian torsion at a reasonable time, because early diagnosis is very crucial to be able to salvage the ovaries. Let's understand what a normal ovary looks like, because if you understand what normal looks like, it will be fairly easy for us to detect what's abnormal. So ovaries normally have this oval appearance, and the most important thing about a normal ovary is the randomly distributed follicles. So the follicles will be everywhere, more centrally, peripherally as well, not just in the peripheral chain of beads kind of an appearance, which we will see later. As far as the vascularity of the ovaries is concerned, you should be able to get both central as well as peripheral flow, as you see here. Again, it's a very scattered flow pattern with randomly distributed follicles, so you should be able to get a decent amount of central flow as well. Do keep in mind that the function of the ovary could be asymmetric, hence you could get some asymmetricity in the flow normally. So there is always a dominant ovary, and that would normally give you a low resistance flow, as you see here. And this is the same patient, while the other ovary would be a dormant ovary, and that would be slightly higher resistance. So keep in mind that normally also you can have this asymmetricity in the pattern of color flow. Let's look at the vascular anatomy, because that's crucial for the understanding of ovarian torsion, particularly the arterial supply. Now, ovary has a dual arterial supply. It gets supply from the ovarian arteries, which arises from the aorta, just inferior to the origin of the renal arteries, as well as the uterine artery. So the adnexal branches of the uterine artery, which arises from the internal iliac artery, also supplies the ovarian artery. Hence, there is a lot of confusing picture in the color Doppler appearance of ovarian torsion. The venous drainage, the right ovary drains into the IVC, while the left ovary drains into the left renal vein. So ovarian torsion is defined as partial or complete rotation of the ovarian vascular pedicle, which results in obstruction to the venous outflow first and the arterial inflow, and that is why you will see this variable appearance. It's most commonly seen in the reproductive age group, and the clinical presentation in the ideal setting would be acute sudden onset pelvic pain with nausea and vomiting. So ovarian torsion may involve the ovary as well as the fallopian tubes, and hence the ideal term to use would be an adnexal torsion rather than just an ovarian torsion. A fallopian tube torsion by itself is very rare. I've seen only one case, and it can be very difficult to diagnose it preoperatively. This is one such case which was surgically confirmed to be an isolated fallopian tube torsion, but which was on imaging diagnosed only to be a hydrosalpinx. But because of the excruciating tenderness, patient was taken to surgery and was found to have an isolated tubal torsion. About 50 to 80% of ovarian torsions are associated with an underlying mass, and that mass could be a tumor, it could be a cyst, it could be just a hemorrhagic cyst for that matter. The most commonly associated mass is a mature cystic teratoma. And here is one case where it's practically impossible on grayscale to say whether the ovary is torsed or not, but the clinical presentation was very suggestive of torsion. In children, you may not see any associated mass, so do keep in mind that you may not have a lead point in the pediatric age group. Let's look at some of the ultrasound findings. So unilateral enlarged ovary. Now compared to the testicular torsions, in ovarian torsion, the grayscale findings are extremely important and much more important than the color Doppler findings. So look for that asymmetricity, look for the enlarged size of the ovary. So this is the contralateral ovary, which is looking very normal in size, less than 3 centimeter, randomly distributed follicles, compared to this ovary, which is enlarged, greater than 4 centimeter in one axis. Along with that, you get what is called a string of pearl sign, which is basically small, uniform-sized epithelial cysts in the periphery of an enlarged ovary, compared to the normal ovary with randomly distributed follicles. And whenever the ovary gets torsed, it tends to get pulled or twisted to a midline location. And again, CT here can be a little more helpful in locating the ovary. On ultrasound, if you can see the ovary right behind the uterus with the other grayscale abnormal appearances, you should get suspicious of ovarian torsion. So here are 3 different cases on CT where there's an enlarged ovary anterior to the uterus. This is the uterus here in another case with a twisted pedicle and another enlarged edematous ovary, more midline. And another one here, which is posterior to the uterus with a large amount of hemorrhage and necrosis. Edematous ovarian stroma, anytime the ovary torses because of the twist in the vessels, it would lead to edema of the ovarian stroma, and that would appear very inhomogeneous. These are 2 different cases which demonstrates a very inhomogeneous central ovarian stroma. Again, in combination with the other findings of an enlarged unilateral ovary and a string of pearls. Do not forget to look at the cine clip because you may be fooled by the underlying lesion and you may not look at the stroma. So as in this case, this patient had this huge cyst, but as you scroll through, you notice that there was edematous abnormal ovarian stroma along with some free fluid. So free fluid is a very non-specific finding. It could be totally physiologic in a woman of reproductive age group. However, again, in presence of a unilateral enlarged edematous ovary, you should look at it with a high index of suspicion. Color Doppler findings, as I said, there is a lot of variability given the dual supply and the degree of torsion. If there is absence flow along with the other findings, which is enlarged ovary and a string of pearls and edematous stroma, that increases the specificity for the diagnosis. You should also keep an eye for an abnormal flow. So whenever there is a twist, you may see this tortus parvus waveform within the ovary. Again, a background of an abnormal ovary is a must to make the diagnosis of torsion. Lee in 1998 described what is called the whirlpool sign or the twisted vascular pedicle, which is seen here. So whirlpool sign basically just represents a twisted vascular pedicle which is seen adjacent to an enlarged or an abnormal ovary. And if you put color on it, you may or may not see color in it, which in fact will suggest the viability of the ovary as well. Some of the grayscale appearances described is a target appearance, which is the most common. The presence of dilated veins. Again, this is an abnormal ovary with a twisted pedicle here. A snail shell appearance, a hypoechoic mass, as well as an echogenic mass. So you could have all these variable appearances, but the key is to find this mass adjacent to the ovary. On color, again, the presence of color definitely suggests viability of the ovary, but you could have a wide variety of appearances. You could have completely absent flow, you could have just arterial flow, or you could have a completely normal flow. So in presence of an enlarged ovary, string of beads, underlying mass, and absent flow, the diagnosis becomes easy. However, if these signs are not present, as I already said, there could be a lot of variability. What is really important is to find that twisted vascular pedicle. And Lee in 1998 in her study demonstrated this sign in about 88% of cases of ovarian torsion. The twisted vascular pedicle comprises of the broad ligament, the fallopian tube, adnexal and ovarian branches of the uterine artery and the vein. They may or may not be a lead point in a case of ovarian torsion. This is a case with an underlying mature cystic teratoma, and because of the patient's symptoms, he was taken to surgery and was confirmed to have ovarian torsion. Another patient with an abnormal ovary, completely absent flow, and an ovarian cystic teratoma right here. It may not necessarily be a tumor. As I said, any lesion within the ovary could make the ovary heavy and can act as a lead point, as in this case, there was a hemorrhagic cyst which acted as a lead point and led to ovarian torsion. It could be as simple as a simple cyst, as in this case, there is a large simple cyst, but there is absolutely no flow in the ovarian stroma here, and you could see it better on the CT as well, a midline location, a large cyst with surrounding fluid, also confirmed to be ovarian torsion. Polycystic ovarian syndrome, it's not a single mass, however, it can make the ovary heavy and can act as a lead point for ovarian torsion, as in this case where the contralateral ovary was enlarged and had a lot of follicles. However, this ovary was very clearly asymmetric, enlarged, and edematous. This ovarian torsion, in fact, was missed initially, and the patient came back after a few days with a completely infarcted ovary. So beware of those asymmetrically enlarged ovaries, such as PCOS, and look for that asymmetric appearances. Ovarian torsion greater than 360 degrees can lead to hemorrhagic necrosis, as was seen in this case. There was this large cystic area noticed in the ovary with some echogenic foci and reverberation artifacts. So these are not calcifications. These were areas of necrosis producing air within the ovary. This is a video of the same patient demonstrating large areas of hemorrhagic necrosis in this enlarged abnormal ovary. You could have antenatal ovarian torsion as well. Ovarian torsions are known to occur in female fetuses as well. And this was one such patient who was found to have abdominal mass, and after delivery was scanned by ultrasound and was found to have this abnormal mass in the left lower quadrant with absolutely no flow. Patient underwent an MRI as well and was found to have a high T1 and high T2 mass, and underwent surgery and was found to have a necrotic torsed tube and ovary with 720 degrees torsion. So the take-home points for ovarian torsion: do keep in mind that grayscale appearance is extremely important for making the diagnosis. Color Doppler can be very variable. The ovary can be enlarged because of an underlying mass itself and still may not be torse, so look at the clinical presentation of the patient. An associated lead point may not be present in all patients, especially in the pediatric population. The color flow can be completely normal. If the ultrasound findings are indeterminate, you can perform CT, and that can help you localize the ovary and look at the entire picture better, and always compare with the other ovary. Bilateral ovarian torsions are not heard of, and therefore if you do see that asymmetricity in the ovaries with the other findings, keep a high index of suspicion for ovarian torsion. Thank you for your attention.